Our next speaker is Professor William Dobbins. We heard his excellent lecture yesterday, and I'm looking forward to hear what you have to say today about size matters, the genetic basis of human megalencephaly. So, Professor Dobbins.
This is 30, correct?
Oh, yes, actually.
Okay. Good morning. Let me just get organized for a moment here. Again, as yesterday, it's a real pleasure to be in Israel, the most interesting country in the world. And one of the things I'm most pleased about is there's no rumor that the Israeli National Transportation Group is going to go on strike again. So hopefully I'll be just fine. That's what I worried about the most from my last trip. Anyway, so yesterday I talked about severe neurodevelopmental disorders like Rett syndrome and many others, autism, infantile spasms, and other severe early onset epilepsies, which cross a very, very large swath of childhood developmental brain disorders. I'm going to be focusing on a subset that by many is thought of as rare, but I'm going to try to throw in between some of my comments the idea that these are not rare, that the disorders of brain growth that I'm going to be talking about today are associated with severe outcomes in some children, with severe early onset epilepsy in many, and with autism in some. So, for example, children with autism who have head sizes larger than +4 standard deviations frequently have mutations of P10, which is closely related to the disorders I'm going to be talking about today. With that, let me go on and talk about this swath of developmental disorders that I've been studying for many years now. This is actually what my lab is working the hardest on over the past several years. So it all began, as it often does, with physician researchers in clinic when I was at Riley Children's Hospital in Indianapolis, Indiana, in the States in early 1990. When the senior clinical geneticist, Dr. David Weaver of Weaver syndrome, was on a sabbatical in Australia, and his junior trainee had a very interesting patient who you see in the images on the right. So she actually called me to walk down to clinic, and over the next hour and a half, we sat there just looking and touching this child in sort of amazement because neither one of us had seen anything like this before. We talked to our colleagues, and within a few weeks had found a second and brought them both back into clinic. These are two unrelated boys you can see on the left of this screen. This is Craig on the larger child here. He had a very large head size. He had a few subtle birthmarks. He had very, very soft skin. He was very handicapped. Over the next couple of years, we found 10 to 12 patients from geneticists all over the US and Canada and published a paper back-to-back with a British paper on the same disorder, defining something that we then called the macrocephaly cutis marmorata telangiectatica congenita syndrome that has been more correctly named megalencephaly capillary malformation now. So that was published in, I think, 1997. And here are the features. Look at the overgrown face, but particularly the facial hemihypertrophy. You can see hemihypertrophy of his right body causing a scoliosis. Also, there's very prominent capillary malformations that you should be able to see better on one side than the other, although I have a little trouble seeing it in the bright lights up here, over here. Prominent capillary malformations over the glabella or over the midline philtrum are very, very common. They may have polydactyly, or they may have webbing of the fingers or syndactyly, and they do not have Ehlers-Danlos syndrome or severe connective tissue problems, but their skin is very, very soft. So some years later, I had a medical student who's now turned into a junior faculty member at in Seattle. Her name is Reda Mirza. She actually was born in the States, grew up in Bahrain, and is now back in the States, really working as my number 2 person on this project. Actually, she's doing most of the work, which is what you like when you're at my stage. Anyway, I handed her this project as a medical student, and a couple of weeks later, she handed me a near-finished draft of a new syndrome that we called megalencephaly, polymicrogyria, polydactyly hydrocephalus syndrome. It's really very much the same as the first syndrome I showed you, but they don't have any skin or other changes outside the brain except for occasional polydactyly. These two syndromes prove to be relatively common. Their head size is large. Their body size, their length and weight tends to be normal, but their head size is not. So in this paper that Rader published in 2012, she did a careful head size curve. What I want you to see is that a few patients have normal head size or only mildly large head size at birth, but by the age of about 1, they are typically larger than +3, and most are larger than +4 standard deviations. So they have very large head sizes. So just to give you some aspect of how common this is, macrocephaly is common. So hydrocephalus is a rare cause of large head size. Most children with large head size have large brains. So if you define it as +2 standard deviations or larger, it's 2.5% of the population. That's a little soft. So if you define it as +3 standard deviations, then that means that 0.13% have macrocephaly, with the vast majority megalencephaly. If you take the population of Israel, which I just looked up as 8 million, that means that 10,400 individuals in your country have megalencephaly. I'm not saying they all have mutations of the pathway I'm talking about, but some of them certainly will. The manifestations here are protean, and so any clinic you happen to go to, certainly in a children's hospital or children's clinic, you are likely to see at least some of these phenotypes. Mental retardation or intellectual disability is common, and it varies from severe to minimal. Seizures are common, as is autism. The seizures are often among the most severe we ever see, including infantile spasms. For neurosurgeons, hydrocephalus is common, as is Chiari malformation and syringomyelia. How are those linked by a single gene? Cardiology, I have had sudden unexpected death in epilepsy, as well as cardiac dysrhythmias. Vascular anomalies or cardiovascular anomalies are less common but occur. There's lots of skin abnormalities. Obstetrics, obviously these children can have very large head sizes, which cause lots of troubles during birth. Oncology. This is not widely recognized, but there appears to be a slightly increased risk of Wilms tumor in children with mutations of these genes, or with these syndromes. And you can see some of the other disorders. Virtually every system that you can think of can be affected by this class of disorders. Here's one. So you can see the ventricles here look somewhat large, so they are hydrocephalus, and the one in the lower right has been shunted. So what we actually found, and this is data from Brada's 2012 paper, ventriculomegaly in 81%, hydrocephalus defined as a neurosurgeon placing a shunt in 40%. So it's a common manifestation. So too is Chiari. So in the neurosurgical literature, the best understood pathogenesis of Chiari malformation is a normal brain with a normal cerebellum in a small posterior fossa. But turn that around. What happens if you have an abnormally large cerebellum in a normal posterior fossa? It's the same thing. And when you talk to neurosurgeons who are expert in Chiari, they will tell you that sometimes they see a posterior fossa that is too large and they don't really understand why or how the child gets Chiari. Perhaps you can now. Here's one example of a megalencephaly with a very large cerebellum squeezing down into the upper cervical cord. Here's a second unrelated child. Here's a third. This is quite common. And so of those two syndromes that I described initially, MCAP and MPPH, it was some pushing down of the cerebellar tonsils into the low part of the posterior fossa was seen in, let's see, 27 out of 40. What is that? That's a lot. That's more than half, 2/3. That's not Chiari, but it progressed in 7 out of 27, which is about 25%. That's Chiari malformation. And several of those children had posterior fossa decompressions. So Chiari malformation is relatively common. I don't have good numbers for syrinx. It's less common than Chiari, but it certainly occurs. Sometimes you can recognize this because the corpus callosum gets massively enlarged. Perhaps more importantly, many of these children have a cortical malformation that looks like polymicrogyria. It's often asymmetric. You can see mild, severe defects in this child with here, and a mild change over here. When you look at other children, here's an example. You see some less severe PMG that is symmetric here and over here. Okay? Same thing here and here. It can be relatively subtle. Certainly this is associated with increased risk for epilepsy. All right, so we have 2 syndromes so far, 2 and counting. Here is the MCAP syndrome, in which there's the vascular malformations or the capillary malformations of the skin, extra fingers, polydactyly, tissue webbing, syndactyly, and many other features. And here is what the children look like with just the brain alone, although some of them have a 6th finger. MCAP and MPPH. All right, I thought that these were 2 separate syndromes, but wasn't sure, so I compared those children with the skin abnormality versus normal skin with the fingers. When you look at any finger anomaly, either a 6th finger or the tissue webbing, the syndactyly, I found no significance. But when I compared the vascular malformations of the skin with the tissue webbing or syndactyly, down here, somewhere at the bottom right, if I can get my cursor to work, which I could not, it's the bottom right, you see a highly statistically significant association. And the same thing was seen with somatic or body overgrowth, particularly hemihypertrophy. So I thought they were 2 syndromes that I defined as you see here. So I used these and sent, back in the days when exome sequencing was just becoming available, I sent off 4 families. Here is one of the first with MPPH. We found de novo sequence changes in 2 children with in the AKT3 gene. I'll talk about that gene in a little bit. At first, we didn't believe it. I didn't believe it in particular because I had published a paper showing that deletions of AKT3 caused microcephaly. Here's one example of a child with a very small deletion of just AKT3 who had significant microcephaly, brain too small. But of course, this was not a deletion or inactivation of the gene. It was an intragenic mutation that could be either a loss of function or gain of function. There was already evidence that other proteins could have, or this gene could have a gain of function. So here is a similar mutation in a mouse model that was already available in the literature. It was described as an epilepsy mouse model, but if you look even very quickly at the mouse's brain, you'll see that the mutant had a very, very large brain, megalencephaly. In addition, a related gene called AKT1 had recently been shown to be a gain-of-function mutation's cause of Proteus syndrome. And just a month or 2 before our paper came out, Ann Poduri et al. From Boston Children's showed the mutation of this gene in hemimegalencephaly, a cause of severe childhood epilepsy. So that's one gene. We then started focusing on that pathway, and in a family with 3 affected children, which is very rare, we found autosomal dominant or heterozygous de novo mutations in all 3 children, suggesting a mosaic mutation in the parents, either in a gonadal mosaic mutation in either mother or father, because in blood, the mother and father were normal. In a different gene that is a regulatory unit of this pathway, we found a recurrent mutation, the same mutation in, at this point, I think 11 children, and it's now up to about 19. Finally, we turned to the MCAP, the more severe syndrome with the syndactyly and skin changes, and found mutations of a gene called PIK3CA. However, these were different because the mutations were not seen in every cell, but somewhere between 5% and usually 30% of cells, indicating a mutation occurring after conception, a postzygotic or mosaic mutation. And each time I talk about a mosaic phenotype, I'll have a little red triangle in the lower left corner. All right, so we had 13 mutations out of 22, and overall, we found mutations in one of these 3 genes in 75% of our patients with these 2 syndromes. At the same time, Dr. Joe Gleason's laboratory demonstrated mutations of the same genes, PIK3CA and AKT3, in hemimegalencephaly, a cause of severe childhood intractable epilepsy. These are the 4 with the PIK3CA mutations. All right, so here is the pathway. What I want to point out here is we'll later be talking about RTKs because these are receptor tyrosine kinases that start the whole process of this signaling pathway. Here is PIK3CA and PIK3R2. Here is AKT1, 2, and 3, and for us, AKT3. And there are some other, here is tuberous sclerosis. And here are some other megalencephaly genes down here that I'm not going to focus on today. So I want to have time to sort of get to 45. I'm just calculating time because this was not set quite right, 15 minutes. All right. So what I want to do here is to focus on some of the broader phenotypes we see and then spend a little bit of time, actually more than a little, on ideas of how we can actually treat these children, a novel concept. All right, so here we have a range of disorders, clinical disorders, that have all been described separately as different diseases by different clinicians, both involving the brain and the body. For example, Klippel-Trenaunay-Weber syndrome, now called Klippel-Trenaunay syndrome, Cloves syndrome, and isolated enlargement of the fingers. So here is Cloves syndrome, which is a striking body overgrowth syndrome with lymphatic malformations, fatty overgrowth or lipomatosis, body overgrowth, capillary malformations of the skin, etc. This baby looked terrible, although by the time she was a couple of years old, she looked much better after some surgical operations. Her defect started at about the nipple line and went down to her toes. She actually had no phenotype, no overgrowth in her brain, luckily for her. Here is a paper from the Warman lab in Boston demonstrating mutations of the same gene, PIK3CA, the same gene as the MCAP gene in children with Cloves syndrome. They're different mutations, but the same mutations as shown in the hemimegalencephaly. I'll show that in more detail later. Here is a Cloves-like syndrome called fibroadipose hypoplasia that I think is the same syndrome. But if you want to see some really striking overgrowth, look at this woman's foot. This is in the lower left of the image right here. Okay, so that foot is about 10 times as large as a foot should be. Okay, and here is isolated macrodactyly, or isolated enlargement of several fingers, all due to mutations of the same gene, PIK3CA. Here is the most interesting patients I've seen with this, a child who had a mild Cloves phenotype, if you look at the overgrowth of her hands and her feet. But she also has striking enlargement of the brain. This is not just megalencephaly, but it has the severe cortical dysplasia characterized in hemimegalencephaly, but it's on both sides. How can you have bilateral hemimegalencephaly? Here's a child with a PIK3R2 mutation with a typical standard mutation with very large head size and the cortical malformation polymicrogyria. Here is the brain scan of a child with polymicrogyria, a mutation of PIK3CA, normal head size. So it's not just for large head size anymore. And then we go from those obvious brain overgrowth phenotypes to hemimegalencephaly and the related disorder, focal cortical dysplasia. So FCD is a very interesting disorder. It's a relatively common cause of intractable epilepsy. So epilepsy affects something like 1 out of every 200 children. 20 to 30% of those children have untreatable or intractable epilepsy. And of those, some are between, depending on the study, 15 to 40% have focal cortical dysplasia. And half of those are FCD type 2. When you add all that together, focal cortical dysplasia is probably the most common cause of intractable epilepsy in children, and one of the important causes in adults as well. So here are some of the abnormalities that I don't want to focus on, but you can get very large-sized neurons. I think this might be a balloon cell, and you can see the large neurons are, I think those are balloon cells. I can't see them very well, but these are very large, abnormal-appearing neurons. All right, and there are 3 types of FCD with several different subgroups. The type that is linked to the megalencephaly is type 2, FCD 2A and 2B. So here, let me show you what these look like. So on the left, we have a PIK3CA mutation with bilateral severe cortical changes, bilateral hemimegalencephaly that I call dysplastic megalencephaly because, of course, the term bilateral hemimegalencephaly is stupid. On the right, we have hemimegalencephaly, but it's not half the brain, it's the posterior half of that brain. And here is something you have not seen before, not yet reported, although it soon will be by our lab and others. Here's a child with focal cortical dysplasia limited to the occipital lobe with a mutation of PIK3CA. Here it's a little hard to see, but at a lower level, you can see the FCD quite easily, the localized brain overgrowth, right there. This girl is seizure-free following surgical resection of the occipital lobe. Here is a child with an AKT3 mutation, the same mutation causing hemimegalencephaly reported by other groups. You can see the hemimegalencephaly there, but what I want you to focus on is the other side. She's got a little bit of focal cortical dysplasia and the other side, occipital lobe. All right, so out of our first 25 surgical samples, we identified mutations in 4 children. These are limited to the FCD 2A and 2B groups. I do not include FCD type 1 or 3 here. What I want to show you here is the 4 patients with known mutations of this pathway are given numbers, 1, 2, 3, 4. But if you look at all of the FCDs, and hemimegs, right, here we go, here, here, and here, they all have increased levels of the activated form of AKT, which is phospho-AKT. So even though we don't know the underlying mutation, it appears that there is abnormalities, upregulation, or hyperactivation of this pathway in all of the FCD 2A and 2Bs. It's actually 19 out of 20. All right, so we have a range of phenotypic disorders here. And again, I want to run along to get to some of the most interesting stuff. So what we have found in our lab is that the common megalencephaly syndromes, MCAP and MPPH, are caused by mild to moderate gain-of-function mutations, while the hemimeg and cloves are caused by severe cancer hotspot mutations in these genes. So MCAP has been caused by mutations. I'm waiting for my arrow. There we go. You can see here, all the way along, we've got lots of different mutations, maybe 20 of them, whereas hemimegalencephaly and cloves are caused by 3 cancer hotspots commonly and 2 other hotspots occasionally. So 4 to 5 mutations cause hemimegalencephaly and cloves. Everything else causes MCAP. These same mutations cause hemimegalencephaly and cloves and the macrodactyly. When you go on to the other 3 genes, particularly AKT3, the same is true. Most mutations are mild gain of function and cause megalencephaly phenotypes, whereas for AKT3, a single hotspot mutation known as E17K causes hemimegalencephaly. So we have a range of cortical abnormalities here that goes from bilateral hemimegalencephaly or dysplastic MEG to hemimegalencephaly that can be most prominent most frontally or posteriorly to focal cortical dysplasia type 2. Or you can get a less severe but extensive megalencephaly. All right, so what we have then is this pathway. Remember that the pathway starts by trigger with a receptor tyrosine kinase such as platelet-derived growth factor receptors, epidermal growth factor receptors, so EGF and PGGF-A, and a number of others, and right into the pathway. So what I didn't talk about a lot earlier that I showed the sign is there are some specific small molecules or drugs that are known to inhibit these pathways. So when you take a gene and you knock it out, it is hard to replace that gene function. However, when you have excess activation, these are often druggable. And there are a number of drugs, none available clinically at this point, that can downregulate or inhibit this pathway. Some are specific at the Pi3K step, that's for PIK3CA, some at the AKT3 level, and some downstream at mTOR. Many of you will have seen children or known of children treated with everolimus or sirolimus. Many of you would have treated children with this, particularly with tuberous sclerosis. This is also used in cancer. However, in cancer, it controls giant cell astrocytomas in tuberous sclerosis, but as soon as they stop the medicine, they start to grow again. In other forms of cancer, it seems to help a little bit. The mTOR inhibitors have just never been particularly effective in cancers, and there's some question about how effective they are in tuberous sclerosis. But, come on, there we go. All right, so if you look on the left, what you'll see is that this is a paper that shows if you inhibit mTOR with everolimus, it turns out you upregulate AKT, which is a more central actor in this whole pathway. Any wonder that everolimus is not working that well? And if you look on the right, you will see that it turns out that this entire pathway is one of the best-known pathways in cancer. And even though these children have a very low incidence of cancer, we know a lot about the biology of all of these genes and proteins from cancer research. Here is a very interesting study that showed with, I think, liver cancers, but it's also been shown with some hematologic cancers, that everolimus, the mTOR inhibitor, doesn't do very much. But when you combine an AKT inhibitor with everolimus, an mTOR inhibitor, you get much more effective treatment of cancer. Is the same thing true for these developmental disorders? Unfortunately, none of these medicines are available clinically except for the mTOR inhibitors, such as everolimus. That is not likely to change soon. Some of these are under cancer trial right now, but drug companies are slow, more likely to treat cancer than they are to treat megalencephaly. But in concept, do we have any way to treat both AKT3, to inhibit both AKT3 and mTOR? What I'm trying to get around to is novel ways of thinking about treating disorders here that are considered birth defects, but the brain overgrowth syndromes are certainly more than simple birth defects. All right, so let me turn back to epilepsy. We know a lot more about epilepsy than we do about brain overgrowth, hydrocephalus, and Chiari. Many children with focal cortical dysplasia have severe intractable epilepsy. It's often the most difficult to treat that a neurologist or epileptologist ever sees. So, in this one study from, I think, Korea, but this is similar to experience we have in Seattle, they treated children with 2 medicines and were able to get control in 13%. When they tried a third medication, it worked in 1 out of, I think, 25 children. 1 out of 44 children. Not very effective, 2%. When you tried the ketogenic diet, it worked in 33%. Surgery was more effective. So it appears that the ketogenic diet is not just a reasonable treatment for the epilepsy of focal cortical dysplasia in hemimeg, it is by far the best treatment, overwhelmingly better than medications. Why? So you look in the literature 10 years ago, or 15, nobody knew why the ketogenic diet works. Now there's about 5 or 6 different mechanisms, but there's one that's really interesting. If you look here in the hippocampus, they put a rat on the ketogenic diet. And what they found was that it downregulated, and you can see that right here, the yellow is the ketogenic diet, it inhibited or downregulated AKT. It also downregulated mTOR, downregulated both of them, just like those medication combinations. It wasn't very powerful, but it did it. It actually worked better, more robust in the liver than it did in the hippocampus, so perhaps brain is a little more difficult. So the ketogenic diet is obviously far from an ideal treatment, but in concept, it inhibits both AKT and mTOR. Is that why it works in focal cortical dysplasia? Obviously, the plan would be to go back to the pathway and try some of these different medications And what would happen if you treated a child with both mTOR and the AKT inhibitor, what's it, MK2206? Boy, wouldn't that be interesting? Could it treat the hydrocephalus or the brain overgrowth, the megalencephaly itself? Clearly, we don't know the answer to that, but that's at least the questions raised. So what we have is some apparently rare disorders that actually are more common when you look for them, and that appear to have overlap with things such as megalencephaly, the common less severe forms, Chiari malformation, hydrocephalus, focal cortical dysplasia, and intractable epilepsy, and all sorts of body overgrowth, for example, lymphatic malformations. All of these, affecting so many systems, are potentially treatable. This is a new concept. So rather than, say, treating the epileptic seizures with a Dilantin or some other medication to treat the excitability, an anti-seizure medication, can we find a true anti-epileptic medication that goes directly to improve the underlying basic cause of the disorder? The same could be true for autism, at least when it's caused by this pathway. So there's lots to do over the next 10 years, but this is sort of a proof in concept of what we need to be thinking about in developmental brain disorders. Thank you.
Thank you very much. Any questions? Great. So,
I have a question. Question?
Stand up. Go ahead.
In your idea of treating these disorders, how much damage do you think is already present at birth, and are you thinking of prenatal treatment as well?
It's a really interesting question. In the U.S., it's less relevant. We are nowhere near as good at prenatal diagnosis because, of course, of the timing differences. The megalencephaly it clearly progresses rapidly over the first year of life. Many of these children do not start seizing until several months of, and sometimes several years of age. So I think that treatment from birth onward will certainly be effective. Now, could it be even better if you treat earlier? Of course. I think the problem is affecting growth. You certainly will need to be careful because if you block both AKT and mTOR, it would affect probably every tissue, not just the brain. So that's going to be a very complicated question. I think what needs to happen is we need to try these postnatally, preferably in the first year or so of life first, and then extend that to prenatal. Some of these are going to be easy to diagnose, but the PIK3CA mutations in focal cortical dysplasia and hemimegalencephaly can affect as low as 5 and 20% of the cells in the affected brain and none in blood or saliva. So making a molecular diagnosis is difficult, and in prenatal it's going to be, in the mosaic cases, it's going to be more difficult. One of the interesting questions is what would you see in amniocytes or chorionic villi? Really interesting question.
Thank you very much, Professor Dobbins, for both your talks today and yesterday.